Dear my students, I would like to do this lecture face by face with you, but unfortunately because of these pandemics of COVID-19, we have to do this in this virtual meeting room. So I just wanted to say you hi with my view, but I will close my view right now because the file will be the file size will be very high. So I will continue like this. Today our lecture will be on retinal examination methods. You know, we have first direct ophthalmoscopy. We will start with this. This is the easiest one. It's a monocular examination of retina, and it gives the 8 to 10 degrees of retinal view. It gives a real and direct image of the retina, and the magnification is quite high, like 15 times. However, it's a monocular examination and it gives a very narrow area of retina. We usually, as ophthalmologists, don't use direct ophthalmoscope. It's used by general practitioners, pediatricians, or neurologists mostly. What we use is usually indirect ophthalmoscopy as ophthalmologists. It's been invented in 1947, and it's a binocular examination. It gives 3D picture of 3D examination of retina so that you can understand the retina in 3D. And it can be done with slit lamp or binocular indirect ophthalmoscopy with helmet, as you see here, or like in this picture with slit lamp. We use some additional lenses to focus on the retina. We can have a very large view of retina, which is like 30 degrees as compared to the direct ophthalmoscopy. You remember it was at most 8 to 9 degrees, 8 to 10 degrees, but now we can view the retina at like 30 degrees so that we can examine the peripheral retina with indirect ophthalmoscopy. That's why we prefer this method more. But it has some drawbacks also, of course. It's a real but inverted image. It's a reverse image. So what you see is just the reverse of the real image. You can use it with this helmet-like binocular indirect ophthalmoscopies. Magnification is like 2 times or 3 times. It's much less than the direct ophthalmoscope, but the area that you can view is much larger. It's very important for babies to examine the babies or children under 3 years of age, or for bedridden patients, because they cannot sit in the slit lamp, before the slit lamp. So this is how you use it. And the image through the indirect ophthalmoscopy is just the reverse, as I told you. This is the normal object, the retina. What you see is like this. So it's just the reverse. So you have to convert the picture in your mind. And you can do it also through the slit lamp, as you see here. With the slit lamp, you use again some lenses like 90 diopters or 78 diopters, and you see a view like this. You see larger area with a smaller magnification. It's a real and inverted image again. We also have some contact lenses. These were non-contact lenses. As you see, you don't touch the eye. But we have also some contact retinal lenses, like three-mirror Goldman lens. As you see here, it has 3 mirrors. There's a central lens and then 3 mirrors. Central lens gives a direct real image, but the mirror lenses gives reverse image. And one is for the equator retina, in the equator, one is for the peripheral retina. This one is the most peripheral retina, or for the iridocorneal angle area. So you can examine a very large area and it's very good for peripheral retinal examination. We also have some other lenses, but I won't go into detail. And we use these contact lenses also for the argon laser applications, argon laser photocoagulation to the retina. And we also have ocular ultrasonography. We ophthalmologists do the ultrasonography by ourselves. You may know this, you may have seen this already. You see that based on the ultrasonography is based on the propagation and the reflection of sound waves. It has an A scan and B scan. A scan shows amplitude, and B scan stands for brightness. You see, A and B is for brightness. This is the machine, and this is how do we use the ultrasonography. It's through the lids mostly. We have a B scan like this. So what we use usually is 8 to 20 megahertz ultrasonic device. This is the frequency of the ultrasonic device. And in A scan, we have just a vertical spike. It's just one dimension. When the echo of the ultrasound increase, the amplitude also increase. As you see, retina has 100% amplitude, and the lens has 100% amplitude. Vitreous is almost 0%. And B scan is, for grayscale, it is brightness as dots, and you see it in 2 dimensions, not like A scan, which is just 1 dimension. This gives a view of 2 dimensions, and when the echo increases, the brightness also increases. And in standard echography, ultrasonography, we use both A scan and B scan together. Where do we use ultrasonography? The main indication is the opaque ocular media. It can be because of corneal opacity or hyphema, filling the anterior chamber, or maybe the pupil is too small to see the retina, so for miosis, or if you have cataract or pupillary membrane, or if you have vitreous hemorrhage, you can use this. Although you have a clear ocular media, you can have some mesh lesions, and to understand the inner structure of that mesh lesion, we need ultrasonography. For example, if you have an iris cyst or tumors or ciliary body tumors, or in the posterior segment, you can have choroidal malignant melanoma or other tumors, choroidal metastasis, or choroidal detachment, or retinal detachment, which is exudative. To understand what is the composition of the retinal detachment, you need this. In addition to all of this, you need to do ultrasonography for intraocular and intraorbital foreign bodies. I'll show you some examples. This is how we do the ultrasonography through the lids, and we see the picture from the panel. And when we have a vitreous hemorrhage, as you see here, we have hyperechogenic material in the vitreous cavity. This may be an old one or a very fresh one, which is less hyperechogenic. Or we can detect retinal detachment, as you see here. Retina gives 100%, almost 100%, as you see here. We use both A mode, amplitude, and B mode together. And here, for example, you see the A mode, which is 100%, so that it's a retina. So we understand that if it is retina or just a membrane. Again, another 100% spike, it is retina. So these are all retinal detachment ultrasonographies. And we can also see if it is a tractional one. As you see here, we have some membranes causing traction over the retina, like in proliferative diabetic retinopathy. And here you see some membranes causing traction, pulling the retina, causing traction and retinal detachment. So these are very important, especially if you have a vitreous hemorrhage. If you can't see it and you do that, you understand. And this is choroidal detachment, which may occur secondary to some trauma or secondary to some surgeries, intraocular surgeries as a complication. You see, you see the surfaces are very smooth and convex. This is a kissing choroidal detachment. You see, from nasal and from temporal to choroid comes together, and it's a hemorrhagic choroidal detachment. You see the hyperechogenic material under the choroid. This is because it's hemorrhagic. But you can also have a non-hemorrhagic, just serous choroidal retinal detachment. You see again convex dome-shaped choroidal detachment is different from retinal detachment. The appearance and configuration is different. And this is an intraocular foreign body, and it gives a reflection behind it. This is very typical, this reflection. So this is intraocular, probably metallic foreign body. And this is a mass lesion, which is choroidal melanoma, which is a mushroom shape. This is very typical. There's hollowness in the base. And when we look at the A mode, which is very important to make the differential diagnosis, you have a high spike and then a decremental low internal reflectivity. This is much important to make the differential diagnosis, much important than even MR. So ultrasonography is very important for choroidal melanoma and for most of the tumors of the choroid. And you see the internal reflectivity is decreasing. This is typical. And we can see also, we can use it also in persistent fetal vasculature. As you see here, they come with leukocoria with fibrovascular membrane behind the lens. And when you do the ultrasonography, there is a connection between the optic nerve head and the lens. This is very typical for PFV. So after ultrasonography, we have another very valuable device in retina, optical coherence tomography. You see the machine here. What is this? It is actually ultrasonography analog. So it doesn't have any radiation or anything like that. So it's a very non-invasive method. It has 40,000, sometimes 70,000 A modes coming together and forming this almost histologic-like section of the retina. You see, this is the section of the fovea, and you can see all the layers one by one. As you see here, it is like a histological section. All the layers like photoreceptor, nuclear layer, bipolar cells, and ganglion cells, and nerve fiber layer. And this is the retina pigment epithelium, external retinal, external limiting membrane, everything you can see one by one. So it's very valuable for us. For example, in age-related macular degeneration, as you see here, you see these drusen, which are cream-colored depositions at the level of RPE. As you see here, you can see the elevations, very typical of drusen. So this is dry type age-related macular degeneration. When it is a wet type age-related macular degeneration, you can have the choroidal neovascular membrane together with intraretinal cyst or subretinal fluid. This is the choroidal neovascular membrane and fluids. You see, it's completely different from the dry type. So you can make the distinction very well with the OCT. And another case with age-related macular degeneration, you have subretinal hemorrhage, and you see the fluorescein angiography, but also you have the subretinal fluid and choroidal neovascularization indicative of wet ARMD. You can also have intraretinal cyst in macular edema caused by, for example, diabetic macular edema. You can assess this. Subretinal and intraretinal edema can be seen very clearly with this OCT examination. Vitreomacular traction and macular holes are also very easily detected. This is vitreomacular traction. You see the fovea has formed a cyst because of distraction, and then distraction may end up with a macular hole formation. This is a very fresh one, and this is an old macular hole, and this is after the operation. And this case has been operated, and the fovea is almost normal after the operation with vitrectomy. And you can see the epiretinal membranes, which is not very clear, just ophthalmoscopically. You see this white thin layer, hyper reflective layer. It's epiretinal membrane. Since it contracts, it causes some cystic changes in the fovea. Foveal contrast change. Or you can see just some wrinkling of the retinal surface and the white hyper-reflected epiretinal membrane. So these are for surgeries, of course. So fluorescein OCT is very important for retinal examination. Another very important tool is fundus fluorescein angiography. Fluorescein angiography is very old and very useful examination method for retinologists. It's the picture of retinal vascular vessels and retinal circulation. It gives a very good view of retinal new vessels, pathological new vessels, and also the ischemia and vasculitis, cystoid macular edema, optic neuritis, choroidal vessels, everything. So you can easily determine those pathological vascular changes. As you see here, you can see vasculitis, leakage from the veins, or pathological vessels, or tumor vessels, or telangiectasis, ischemia, CFN neovascularization, Coats disease, everything. You see central serous chorioretinopathy. It's very, very helpful for us. This is branch retinal vein occlusion, so it can be very useful for such things. What's the principle? It absorbs blue light and emits yellow-green light, and we give 10% sodium fluoride, which is not a contrast material, but just a fluoride, and we examine it under blue light. And this material, fluoride, is metabolized by liver and excreted by kidney. How do we do that? We give the fluoride, which is, you see, orange colored, from the antecubital vein, and within seconds it comes to eyes, and the technician takes the pictures, and then you examine the pictures. So fluorescein is not a contrast agent, but it's something like a dye, so the skin becomes yellowish, urine becomes darker. It may rarely cause nausea and vomiting and sometimes urticaria. These are rare, but very rarely it may cause, as everything given from the intravenous, parenteral, or anything, any drug given, it may very rarely cause anaphylactic reaction. It has some phases, angiography phases. It first comes to choroid, then to retinal arteries and veins, and recirculation phase. This is the early phase. In the early phase, you see there is nothing in retinal blood vessels, but only the choroid becomes lighter, stained, and then it comes to arteries first. The veins are empty at the beginning. Then it comes to veins, and as you can see here, you can easily see where the ischemic parts are, as you see here. You can't see this ischemia by looking at the color picture or fundoscopy, but this is the main thing that you can see only with fluorescein angiography. You can also see the neovascularization on disc, like this in this case, secondary to ischemia, which develops secondary to ischemia, and neovascularization elsewhere, which is called NE. As you see, this is a diabetic case. There are ischemic areas, and some neovascularization has developed secondary to ischemia. This is a late branch retinal vein occlusion in fluorescein angiography. You see, this is normal capillary staining, but in these areas, you don't see any capillary staining because they are like dry tree. So there's no small branches. This is very typical for late ischemic branch retinal vein occlusion. And we take a series of pictures to see the early and late phases together. You see the neovascularizations somewhere in retina. Another case of central retinal artery occlusion, you see all of these branches are empty, both arteries and veins, but there is only a small part of retinal vessels which are not empty. This is cilioretinal artery. This is a central retinal artery occlusion, but this part is supplied by cilioretinal artery, which is just an anatomical variation, which is present in 10 to 15% of patients. This cilioretinal artery is a branch of ophthalmic artery. It's separate from central retinal artery. And this is, the fluorescein angiography is also very important to diagnose the vasculitis, because as you see here, normally vessels do not leak the fluorescein inside. But if there's a vasculitis, as you see here, fluorescein leaks through the retinal blood vessels, so that you understand that there is vasculitis in those retinal blood vessels. You can't understand this with fluorescein angiography or anything else, but only with fluorescein angiography. And again, you see in fundoscopy, you have something here near to macula, in the papillomacular bundle area, and some hemorrhage around it. What was that? We can understand that it's a choroidal neovascular membrane under the retina. This is the early and this is the late stage. So it's very nice to see in fluorescein angiography. Another choroidal neovascular membrane, which is secondary to age-related macular degeneration, very nice to see in fluorescein angiography, late staining of the choroidal neovascular membrane. And lastly, I will talk about the OCT-Angiography. This is a very new technology which appeared during the last 5 years, I can say. And it's a new and non-invasive diagnostic method. It gives the vascular structures of the retina and choroid in almost 3 dimensions without any need for contrast agent or fluorescein injection. So that's why it's very non-invasive method and very easy and quick method. It's the principle is based on the detection of particle movements. What particle? The particles in the blood vessels, I mean the erythrocytes. It detects the erythrocyte flow so that you can see the blood flow, so that you can detect the pathologic vessels with OCT scans. As you see here, it gives much more detailed view of macular vessels and macular capillary vessels, and you can detect very small pathological vessels, as you see here, and it can detect macular ischemia at an earlier stage and choroidal neovascularization. So it's a very good and non-invasive method. I think that's all for what I want to tell you about the retinal examination methods. I hope to meet you in better health days free of pandemic. And for more information and videos, please visit my website. Thank you. Have a nice day.